Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. This is a very interesting video which I am sharing now and will clear few concepts regarding posterior zonular dialysis. I have already posted and described two types of subtle zonulopathy. In this video I have posted last year, and you must see this video if you have not seen Unseen Universe of Zonules. So there are two types of zonulopathy which might be localized, like anterior zonulopathy and the posterior zonulopathy, and another video which describes intraoperative dialysis management and how to differentiate peripheral posterior capsular rain from dialysis. I think both these videos are must watch, and now we'll come back to the interesting video which I am going to show. A very regular case of FECO, grade 1 to 2 cataract, and good CCC. You can see during CCC there were no signs of any zonular weakness, a good cortex cleaving hydrodissection there, followed by chop and emulsification of the pieces. Now all throughout the surgery you can see that I identified any signs which suggested that there can be a zonular weakness in this case. The bag appeared extremely stable. The emulsification process was uneventful. The flowability was good. There was no vitreous thrust or any movement of the bag throughout the procedure. And once the emulsification was done, I am going to move to cortex aspiration using coaxial IA. Again, a very regular response from the bag as I start the cortex aspiration, but as I move on to area which is closer to subincisional area, you find this happening. So we watch it again. You can see that the posterior capsule comes up and gets dragged, indicating that there is a weakness of zonules, and it's restricted to posterior zonules because you can see the anterior capsular rim is quite intact. Despite that, you can see the zonular weakness in almost 4 to 5 clock hours. You can see here almost 4 clock hours of posterior capsule which is coming up, and I have to release the cortex very carefully here not to catch hold of the posterior capsule in this process. So very carefully I release the cortex from the posterior capsule, and as I polish the posterior capsule you will find that there are wrinklings which are happening. So again I am going to show how the cortex was carefully released, and you can see the posterior capsular folds there, showing that in that area the zonular support is weak, and it's not a complete dialysis because you can see the anterior capsular rim there is still quite stable. As I polish the posterior capsule, you can see that the posterior capsule has become more redundant now. So how to tackle this issue? So once we inject the OVD, you find that the bag appears normal. I try to judge whether the posterior capsule is folding back. It doesn't. So what I do is I remove some amount of OVD because I want to be sure whether it's just the posterior capsular dialysis or posterior zonular dialysis, or if there is a peripheral PC rent, because the management is totally different. If there is a PC rent, I am not going to put CTR. I will be placing IL in the sulcus. But if it is just posterior zonular dialysis, I can put CTR. Now once I inject OVD, you can see there is no visco going inside. This was shown by me in earlier video to differentiate between peripheral zonular dialysis and posterior capsule rent. Once we inject OVD, what we find in zonular dialysis is that the bag regains its former contour, and in case of peripheral posterior capsule rent, there is eversion of the edge of the tear and the visco will go into the vitreous. Here it is clearly just zonular dialysis and not posterior capsule rent. So I am going ahead with insertion of the CTR. This is the technique that I follow. I use the left hand Sinski to make sure that the CTR goes into the bag, and then I use the microcapsulorhexis forceps to push this CTR into the bag. Once CTR is in place, the bag is very stable and I can implant the pre-planned toric IL in this case without any issue of bag stability. So in this video you have seen the difference between peripheral rent and dialysis, and also how to notice the posterior zonular dialysis and how to tackle it. I hope this video was useful. Do watch my YouTube channel, do subscribe, and also watch my previous videos from my playlist. Thank you.